Trials Unit at the University of York, this is the Research Room. Hello.
Hello.
Welcome to the Research Room with me, Lucy Ather.
And me, Janine Healy.
May is Mental Health Awareness Month. So we thought it would be a really nice idea to do a little mental health mini-series.
Yes, so we're going to be bringing you a new mental health project each week.
So for the first episode, we have Mehreen, Faisal and Karen Coles with us. Welcome to the Research Room.
Hello.
And you're going to be telling us all about your project, which is called SPiRiT-D. So just to start us off, could you introduce yourselves for us? Should we start with you, Mehreen?
Yeah, thanks, Lucy and Janine, for having us here. So hi, everybody. I'm Mehreen. I'm based as a postdoc in the Department of Health Sciences, and I work primarily for the Center for Impact, which is basically an NIHR-funded center to improve physical and mental health together.
Mm-hmm.
And today what we're going to talk about, the SPiRiT-D project, it is a part of the Center for Impact, and I work on it as a deputy lead and as a research associate.
Brilliant. Thanks for coming in. And Karen?
Hi, everyone. I'm Karen. I'm a colleague of Mehreen's, so I also work in the mental health theme in the Department of Health Sciences. And I work alongside Mehreen on the SPiRiT-D project, and I also work on some other projects which are looking at mental health, but also a project that's looking at improving access to hypertension care in South Asia as well. So lots of similar themes.
Brilliant. Great. Well, yeah, I'm really looking forward to learning all about this project because it's a little bit different to ones we've talked about in the past.
Yeah, very different.
Because it's based in Pakistan, isn't it? It's not in the UK like we normally are. We've gone global.
Yeah, we've gone global.
So could you start with just telling us what the long name of your project is?
So basically, the SPiRiT-D stands for Strengthening Primary Care for Recognizing and Treating Depression.
Okay.
Okay.
Strengthening primary care for recognizing and treating depression.
Okay, so we have this little competition to find about the short name. So the short name is SPiRiT-D. Okay.
Yeah.
So how do you fit that into SPiRiT-D?
I think it fits quite well.
Where? So
Strengthening.
S.
yeah.
Primary.
Yeah.
P.
Yeah.
Or recognizing.
Oh yeah.
R.
Yeah.
Yeah.
And treating. T. Depression. D.
Oh, I see. You put an I, two I's in there to make it a word.
Well,
Yes.
you needed some vowels, right?
Yeah, you couldn't have it.
Yeah.
Oh, okay. Yeah. Okay. Yeah.
I think it fits pretty well, that.
It is actually. Yeah.
Yeah.
Now you've had to explain it to me.
Yeah.
Yeah, it's good.
And spirit, that's a nice word. Feels positive.
Oh yeah. Bring your spirits up. You
Yeah,
know.
we tried to go for something that felt quite empowering and
Yeah.
relatable in terms of the project, but also something that's easy to remember.
Yeah.
Yeah, that's important, isn't it, with these things? Oh, okay. Yeah,
Yeah. I think it's quite a good one.
it is actually. Yeah, I'm not going to be picky about the eyes because
Yeah. What are you going to give it out of 10?
Oh, got to go first, haven't I? So I'd give it a 7.
Oh, very good. I'm not copying you, but I would also give it a 7.
So we're so nice, really.
I like
aren't
it. I think, 7 out of 10 because I like the word and I think you fit your acronym pretty well as well.
Yeah.
Yeah. Very good.
You'll take that.
Good.
You'll take that. Okay. So in a nutshell, could you describe your project?
So basically, with SPiRiT-D, what we are doing is we are looking at testing the implementation of a collaborative care model for depression in primary care settings in Pakistan. So basically, just testing how collaborative care model can be used to recognize, treat, and improve outcomes for patients with depression in resource-constrained settings such as Pakistan in the primary care.
And when you say collaborative care, what do you mean by collaborative care?
So collaborative care model for depression is basically an evidence-based model which has been tested for effectiveness in a lot of countries, including high-income countries and low- and middle-income countries. But evidence for it is quite low from low- and middle-income countries. So basically what happens is collaborative care model is a team-based, patient-centered approach to managing depression. There is a team of professionals, including non-mental health people who don't have a background in mental health. They are trained to provide evidence-based therapy.
Yeah.
And I will let later on Karen speak more about it because she's the expert on it. And one of the main elements of the collaborative care model is the task shifting approach. And this is when somebody with a non-mental health background is trained to provide the therapy for depression.
Okay. So it's not just, you wouldn't need a sort of doctor to do it. You could train different people, and then that opens it up to having more people available to deliver the care.
Exactly. And some of the other components of the collaborative care model include population-based screening. So everybody who visits is screened for depression, and then whoever is needing the care, they are provided with that care. And their progress is tracked throughout to check whether there's improvement or if a care needs to be stepped up. So by stepped care, we mean that based on the severity of the symptoms, care is provided. So if the symptoms are not improving, then the care is, intensified or increased. For example, maybe there's a need to add antidepressants along with the therapy.
So that population screening, then, is that where, rather than waiting for people to come and say they have the depression, it sounds like you're kind of looking at everyone to see if they have it, even if they don't say that they do. Is that right? Or have I totally got that wrong?
That's absolutely right. Because depression is such a big public health problem, not just globally, but in Pakistan. Globally, it affects about 280 million people.
Oh, wow.
And it's more prevalent in females than in males. In women, there is a prevalence of 170 million as compared to men, which is about 109 million.
Oh, wow. God, I didn't know
But
that.
in Pakistan, there is depression is the second leading cause for disability adjusted life years, so DALYs, which is basically a metric to assess the overall health burden based on ill health, disability, or premature death. Wow. And there's a huge mental health treatment gap, which means that people who need care for depression, they are not getting it. And that's the reason why, the population-based screening really fits in well with this.
Oh, yeah, because you'll be able to find those people.
Exactly. And one of the other elements of the collaborative care model, which I just remembered, is the case-based review and supervision. The mental health specialists, because they're usually not available in the primary care settings, and especially in Pakistan or other low-resource settings, there is a severe shortage of mental health specialists. So what they basically do is provide that supervision to the counselors or the people who are trained to be a case manager. So they're not doing that on their own because they really don't have a mental health background. They're trained to deliver therapy or to coordinate the care under the supervision of the mental health specialist.
Okay. So you could train people who aren't mental health specialists, but they'll be supervised by someone who is.
That's right.
Yeah.
So you can increase your reach because 10 people can be supervised by one person, and obviously they can then reach many more people.
Yes.
So it's a very efficient way of using your human resources in a situation where you perhaps have shortfalls. So not just in mental health, it can be any specialism really.
Yeah.
You might find that you have specialists in that field, but the demand for that particular specialism outstrips the capacity.
Yeah.
So if you can find treatments and therapies that you can maybe teach somebody else how to do them, then it increases your reach. So it helps to bridge that treatment gap.
Yeah, yeah.
What exactly is the support you're offering that people can be trained in, that they don't need to be experienced trained?
So in SPiRiT-D, we're using a very brief talking therapy, which is evidence-based for the treatment of depression. It's something that we can access here in the UK. So if you went to see your GP and your GP felt that you had symptoms of depression, they might recommend that you go to a talking therapy service where you can access this brief talking therapy. So very basically, what it is we are recognising that there is a link between what you do, your behaviours, what activities you get involved in during the day, and how you are feeling.
Mm.
So some things that you do help you feel really positive. Other things that you do maybe pull your mood down. If you're depressed, you might change your behaviour in an attempt to try and cope with how you're feeling. So generally when people are feeling a bit down, they kind of withdraw into themselves. They avoid doing things, they put things off, they maybe isolate themselves, whether that's physically by taking themselves away from people, or you might just be in a space with other people but not really joining in. And those things sometimes, you might feel like that's a good way to try and deal with how you're feeling. And once I feel better, I'll get back to doing things again.
Mm.
But the problem with doing that is, whilst it might take the pressure off in the short term, while you're just not feeling like you can cope with things, it then doesn't give you access to anything that's going to make you feel better. So you then enter into what we call a vicious cycle of depression, where you're trying to cope, but what you're doing is actually perpetuating the problem rather than helping you to recover. And indeed, it could even make things worse if you follow that pattern over a long period of time. So the therapy that we use, it's called behavioural activation. So, it says what it does on the tin, really.
Yeah.
It's a way of helping people to recognise what they're doing, maybe what started this cycle, what behaviours or activities they're doing that may be perpetuating the problem, and getting to them to think about what things generally in my life help me to feel better about things, and then encouraging people to plan those kinds of activities into their coming week. So rather than waiting till I feel better, I'm doing things to feel better. So over a period of time, if the person's starting to do more things in a very purposeful way, even though they might not feel like doing them, gradually you're breaking that cycle, that circle of depression, and helping people back into recovery. The things that are really nice about this kind of treatment are there's no side effects. So, there's no costs involved other than, if you have to pay for the therapy, which, we hope people don't have to pay for this therapy, which is unlike medications in a country like Pakistan, where often there isn't free healthcare, so people have to pay for tablets.
Okay.
And if you don't have very much money, then the burden of paying for medication obviously has a huge impact on your life and the life of your family. So if we can provide this treatment, teach people how to do this, they've then got the skills to maintain their mental well-being in the longer term. Or if they recognise that they're starting to feel a bit depressed, if they stop doing these things, they can start to do them again to break that cycle. So it's a very powerful but simple therapy.
And that explains why you can teach people to deliver it, isn't it? Because it's a simple talking therapy, basically.
That's right. I mean, it's something that we can all benefit from. One of the unexpected outcomes that we got from an earlier study that we did, which was around taking behavioural activation as we deliver it here in the UK and working with people in Pakistan and another South Asian country, Bangladesh, where we worked with them and lots of people in the community, experts in the field, to adapt the intervention so that it just felt relatable to people living in South Asia. So it's speaking to them in their context. One of the things that we found from doing that work was that not only did it help people with depression, but the people who were delivering the intervention then also made those connections around what I do and affects how I feel, and that helped them to improve their own mental well-being as well.
Ripple effect.
So it's very powerful, and it had all of these unexpected benefits that we hadn't necessarily anticipated, but we were very, very happy to see.
Yeah.
And that's because you involved the local groups to develop a version of it that would fit in their particular environment.
Yeah, absolutely. I mean, there was an awful lot of work went into developing the intervention, making changes to it. Just to give a very simple example of something that we changed, when we talk about behaviours, we group them into 3 categories. So things that you do that help you to establish a routine to your day, your week, some kind of structure or skeleton, if you like. There are things that you do that we could say are necessary things. So these are the things that if you keep putting them off, there's going to be an unwanted negative consequence. So if you don't pay your bill, your phone might be cut off, your electricity might be cut off, so on and so forth. And then pleasurable things. So these are things that you just do because you enjoy doing them or because they help you feel connected to other people. Our community groups and our trainee deliverers of the intervention worked with us and came up with a really nice, simple way to explain that was totally relatable in South Asia. They said, imagine you have a rickshaw. Your rickshaw has 3 wheels. If one of the wheels falls off, the rickshaw doesn't go anywhere. So,
that's good,
so that wouldn't be a relatable way to explain the intervention. Say, if I went into a talking therapy service in York, it perhaps wouldn't, I could understand the context, but it wouldn't be entirely relatable. It would really resonate with somebody who was perhaps going into a clinic in Karachi or Rawalpindi or somewhere like that in Pakistan.
Yeah, it sounds like a really important thing to adapt it to the kind of local setting.
Yeah,
definitely.
Yeah, I think those are the things that are really important when you want to translate clinical application or some research from one setting to another, one context to another, to do that work to adapt it to make sure that it's fit for purpose in the place that you want to deliver it, and so that it resonates with the people who you're hoping to reach.
Yeah. And so you're testing, it's more about the sort of implementation of it, is that right? So you kind of know that this talking therapy works for depression. It's not actually that you're testing, it's testing the best way to deliver it.
That's right.
Yeah. And so you want to put it in primary care settings, is that right? And is primary care, I think, is that GP practices, or is it a bit different maybe in Pakistan? Or
Yeah, so the primary care settings in Pakistan can be classified as private and as public settings. They're a bit different in the sense that the public, obviously, they're free to access. Even if there's a charge, it's very minimal. Whereas the private are different because they would be charging the patients to access it. In terms of where we are working, this is an health education and welfare trust called SENA in Karachi, and they've got primary care clinics, about 40 of them, spread across Karachi, which is a very metropolitan city and a huge city in Pakistan. And they serve one of the most underserved areas in terms of health and also in terms of economic status.
Could you say what the difference is between this country, that's all we know about is the NHS, and Pakistan?
Primary care here in UK is very well developed. In Pakistan, it's not really that developed, and the services are very fragmented. So the physical and the mental, they are provided, they're in silos really. So it's not like under one roof.
So if you went to a GP here, you could access mental health things, but in Pakistan you can't do that.
No.
Okay. And so this would kind of bring those two together.
Absolutely.
Okay. So could you tell us a bit about the background to the project and why you're doing this study?
So the intervention that we're testing is a culturally adapted version of behavioural activation, which is the intervention that we are able to offer as a clinical treatment here in the UK. And we developed this intervention through an earlier programme of research, which the acronym for is DIADEM. So we're sticking with sort of nice, uplifting acronyms. But DIADEM actually stands for Developing and Evaluating an Adapted Behavioural Activation Intervention for People with Depression and Diabetes in South Asia. So you can see, you probably wouldn't want to introduce your programme of work in its entirety. So DIADEM is
you've gone for a shorter acronym for SPiRiT-D.
Absolutely, SPiRiT-D builds on DIADEM. So DIADEM was a randomised control trial to test the feasibility and acceptability of the intervention, and it was all, we found that people liked it, it worked, the public health services could afford it, which is very important because not only does the treatment need to work, the country also needs to be able to afford it as well.
Definitely.
What would happen if you funded the DIADEM behavioural activation? would that mean that you'd have to take funding from some other kind of healthcare?
Right,
And what,
yeah.
what would be the impact of that? So there's quite a complicated economic evaluation goes into this kind of randomized control trial. So we're not just looking at, does it work, but is it affordable, and is it equitable in terms of what's already being provided for healthcare within the country? And in a country like Pakistan, where public health is really underfunded. So we talk a lot about in the NHS about, we need more money in the NHS, and it feels like a bottomless pit.
Yeah.
Well, we put an awful lot of money into our NHS in comparison to what Pakistan is able to put into their public health services. So as a consequence, there are many treatment gaps. It's a huge and growing population. Their health needs are becoming increasingly complex. So their need for health services is growing, but the public health sector is really stretched. So they want to be able to meet the needs of people with conditions like depression, but at the same time, they have to consider that they have very limited resources, not just in terms of money to provide treatments, but also in terms of human resources. So how can you find solutions, ways for people to access treatment where everything is very, very constrained? That's where it comes in.
Yeah. So that was the study where you developed the support, the behavioural activation.
That's right. So that's our culturally adapted version of behavioural activation, which we use as the test intervention in the SPiRiT-D trial. So it's a collaborative care model that we're testing. The intervention that we're using for depression is culturally adapted behavioural activation, which is an evidence-based treatment for depression in South Asia.
Yeah. And then this study, testing how you can implement it, which is really important, really, because once you know it works, that's great, but it's almost harder to figure out how you're actually going to deliver that treatment.
Yeah. And that's the joy of SPiRiT-D, really. It's when you're testing an intervention in a randomized control trial, you've got control over pretty much everything that's happening. But when you then take that intervention out into the real world, well, the real world is a lot more complicated and messy than a randomized control trial. Yeah. So, but those are this is where the real work is done. In ideal conditions, yes, our intervention works, but actually, if you take it out there into the real world, does it still work?
Yeah.
Or are there things that you need to think about changing in order to, sort of be able to, as Mehreen says, scale that intervention up, which just means reaching more people.
Yeah.
Because obviously, I imagine you want to be able to roll it out across Pakistan and not just be something you have to travel to a certain city to be able to get.
Is there any reason why you chose Pakistan?
I think just our research group have really strong links with research organisations in Pakistan. Our research leads, Professor Najma Siddiqui, and her husband, Professor Kamran Siddiqui, do a huge amount of work in South Asia. And another colleague, Dr. Hannah Jennings, also has very strong links with Bangladesh. And, the research organisations in both countries were really interested in working with us.
That makes sense.
And so we formed a collaboration that's allowed us to be able to run trials like DIDEM and also SPiRiT-D, which is the one we're talking about today.
Also, interestingly, over 90% of those in LMICs, which is low and middle income countries, with depression do not receive the care, really. So the treatment gap, which I mentioned, the mental health treatment gap, those, who should be receiving care do not receive it. That's like over 90% in LMICs.
Wow.
So it makes it more, the more reason why we are working in
a place where there's a real need for it.
You make a bigger difference as well.
Yeah.
I mean, as a former NHS mental health clinician, being involved in these projects has been so rewarding because you see the need and you understand the treatment gap, and in a however small a way to be able to reach out and maybe be involved in something that could potentially make a difference to a lot of people in a part of the world where they simply cannot access treatment. It's a really, to say rewarding, it's not really, it doesn't really say enough about how it feels to be involved in that kind of project. And the institutions that we work with, whether they're the universities, but also the organisations, the clinical organisations and the clinical staff that we're working with, they are so supportive and enthusiastic, and they really want this. So it's a real privilege to be able to work with people in those kinds of organisations, and they've worked incredibly hard with us, haven't they, to try and get make SPiRiT-D a reality.
Yeah. Oh, that's really nice. Yeah.
So how does your project work?
So the project uses a mixed methods design and a multi-work stream design, basically. It's laid out in 3 work streams. So the work stream 1 was basically understanding the context and developing the implementation strategies. So to test them, implementation of the collaborative care model. So what basically happened was our teams, they visited the SINA clinics. They observed the everyday functioning of the clinics. We also conducted document analysis to understand what is the policy context around mental health care, and also stakeholder consultations involving patients with lived experience, their carers, the SINA management, and the physicians, the service providers, to hear about what could be the potential barriers and facilitators. So this was basically our work stream 1.
Yeah.
Following this, what we did was we co-designed the implementation strategy. So again, involving the stakeholders to see how these barriers and facilitators could be addressed. And then we did a prototyping phase where we sort of tested the implementation strategies in 6 test clinics to understand.
Like a bit of a pilot.
Exactly.
Right? Yeah.
Just to see what's working, what isn't, where we need to make more changes or, adaptations. And once we had a finalized version, and that's when we moved into the work stream 2, which is testing the implementation of the collaborative care model through a hybrid type 2 effectiveness implementation randomized control trial.
Oh, wow.
It's a mouthful.
That is a mouthful.
Right.
Yeah.
But I heard the words randomized control trial, which we like.
Of course.
Yeah. So I'll speak a little bit more about what I mean by hybrid type 2.
Yeah, please.
So the hybrid trials are basically looking at both the effectiveness and the implementation in terms of whether this shows promise, the intervention, if it's implemented in this setting. And that's what basically hybrid type 2 means, that we're equally looking at not just the intervention working in that context or for that population, but also whether implementing it can be done.
Yeah. So you are looking at whether the behavioural activation that you've adapted, whether that works and how you implement it. You're kind of looking at both.
Yes, so behavioral activation is part of the collaborative care model. So we're looking at the whole collaborative care model.
Right, okay. Okay. So does the whole thing work, and are we implementing it correctly? Does that bit work as well?
Yes.
A hybrid randomized control trial.
And you're comparing standard care to the collaborative care model.
Absolutely. So for the control arm, we have the optimized usual care. We call it optimized because what we are doing is because we are going to screen patients in both the arms, so the control and the intervention. And then on the control arm, the other thing what we are doing is we would be patients who test positive for depression. They would be signposted to depression care. So they provide very unstructured counseling in their usual, as part of their usual care.
Okay, so it's optimized because it's not just nothing.
Absolutely,
they do get a bit more.
So you can tell then if it's the actual bits you're adding on. So the behavioural activation and the collaborative part are actually making a difference.
Absolutely.
And you're randomly allocating people, so it's based on the clinic. So the clinic will be an intervention or a control clinic rather than people.
Yes, we're not
being
randomizing people
individually.
like you would in a a more usual randomized control trial where you're testing a tablet or a therapy or whatever. People don't get randomized. It depends on which clinic they go to, and you go to your local clinic, I guess, usually for most people.
Yeah, which makes sense really for implementing things, because you can't implement something for some patients and not for other patients in your clinic. That would get way too complicated.
You can't force people to go to one clinic or this. So people just come to their local clinic. They don't know if their local clinic is an intervention clinic or a control clinic. And then they follow the pathway that for depression in that clinic, dependent on which arm it is.
So the randomization is the clinics, and the patients don't actually know which arm they're on, do they? They don't know what they're receiving, even though
that's right, isn't it?
It's different.
So they really don't know whether they're in the intervention or the control arm. They could know potentially because how PA is being delivered, and it's termed as behavioral activation. So it would be mentioned on their patient consent forms. So if they wanted to put one and one together, they can do that. But otherwise, because how the intervention is laid out, it's not really possible to blind it. But we are still trying to keep the assessors and the statistician blind to the allocation.
Blinding people where you can.
Yes.
Yeah. So it's more the researchers are blinded rather than the interventionists or the patients.
Yeah. And so the assessors then, what are they assessing? Would that be, I guess, quality of life and depression scores and things like that?
Yeah. So we've got two outcomes basically. One is the effectiveness and the implementation. So the primary effectiveness outcome is our change in depression severity at 6 months.
Okay.
And for our implementation outcome, it is the reach of the treatment. So basically, how many people were enrolled and how many received treatment, such as BA therapy, for example, or the counseling therapy in the control.
Okay. So that's how you'll know how well it's been implemented and how that worked. It's how many people you managed to treat.
Absolutely.
Okay.
And then we have secondary outcomes, which basically are looking at depression and anxiety caseness at 3 and 12 months. So these are other follow-up time points. And then quality of life, functional impairment, and then physical health measures such as BMI and weight, for example, healthcare use and costs. Again, this falls in the economic valuation as well. So these are some other measures that we'll also be looking at.
Yeah, that's really important as well, the cost effectiveness. Yeah. And is there any qualitative work going on? I know sometimes there's qualitative work, some interviews.
Yes, absolutely. So workstream 1, which I mentioned earlier, it was mostly qualitative work within the stakeholder consultations, co-design workshops. And then following this, as we are into the trial now, we are also doing process evaluation. So a lot of interviews and focus groups happening as part of the process evaluation to understand, the processes, for example, the fidelity, acceptability, appropriateness, and barriers and facilitators regarding the implementation. So a lot of that is happening alongside.
So is that with the people who work at the clinics? You'd be asking them lots of questions about how well it went, basically, what they liked, what they didn't like.
Absolutely. And then also the patients, who are a cohort of patients who are enrolled, for example, in the intervention and the control clinics, and just to see how they have engaged and how things are working for them.
So, people have mentioned process evaluations before. And do they make a difference? Do they evaluate how you've delivered this?
So a process evaluation is all about looking in a little bit more depth. So we've talked about whether something is clinically effective. So you can measure outcome scores. So you could say this intervention is effective because this person has recovered. We can measure that quantitatively. But a process evaluation goes a bit deeper. It's asking a lot more of the why questions. So it's getting the context. So that's why talking to people and doing things like observations and all of those kinds of things are really important. So you can just put all of that quantitative numerical information into a context of a real life situation. So if that person went into recovery, what was it about going into recovery that really mattered? So we know the intervention works, but is there something there about maybe the relationship between the person delivering the intervention and the person receiving it? Is there something there, sort of about environmental context? So was this clinic in a good place? Or all kinds of things like that. And through having all of these conversations with the different stakeholders within that study, so talking to the healthcare providers, the managers, the patients, the carers, members of the community, you get that really rich sort of holistic picture of what's actually going on. So the process evaluation part is a really important part of the study.
Yeah. It sounds, it is important, is it? Yeah.
Yeah, no, it sounds like you're collecting loads and loads of data. You're going to have loads. You're going to have loads to work through. You're going to be busy.
Yeah, there is absolutely. And then some of the other measures regarding the implementation, we are looking at the REAIM framework. So
right.
R is for reach. Reach, I spoke about the reach of treatment. And then also we are looking at reach of screening. So how many patients, for example, are screened at least once, And then there is the effectiveness. So we are already looking at effectiveness from the clinical point of view as well. And then A is for adoption.
Okay.
So we're looking at how well it is being adopted as part of their practice in the clinics. So how many, for example, healthcare staff are being trained, and they're practicing actually delivering the intervention. And then we are looking at I stands for implementation. Again, how well it is being implemented. So the healthcare staff, how they're delivering the intervention. And then M is for maintenance, how well it will be maintained after, for example, the trial finishes, and whether, again, looking at, and we'll probably be speaking to more senior members in the management staff and just see what they feel about it, and, how would they like to go on after SPiRiT-D.
Yeah. So for that, do you have to take more long-term measures? Would you come back after, say, a year and see if they're still?
Yeah, so we will be, there's a 12-month follow-up. So yeah, we would be looking at those things.
Yeah, that'll be really interesting to see if they're still kind of using it after 12 months. Yeah. Oh, wow, you've got loads. Loads of stuff to be looking at. So I think now we've got some fun.
We've got the
random questions for
the
you.
new hat.
Yeah, we've got a new hat. This is version 2 of the hat.
Janine's easier to carry hat.
Yeah. So we're going to pull some questions out the hat.
Oh, it's a long one. If you could turn your project into a board game, what would it be called and how would it be played?
Oh,
is there a board game called Chaos? I'm sure there must be.
Yes, I think there is.
Yeah, so if you're playing Chaos, you would probably, all the players would be entering into the game with not too much of an idea of what's going on and how it's all going to work.
There's no rule. No one gets the rules in this book.
Because implementation science can be a little bit like that at first, but gradually it does all come together. But sometimes it can feel a little bit like chaos.
That's a good one.
I like that one.
Yeah. Mehreen, would you have one? Would you play chaos as well?
Oh yeah, absolutely. I think Karen has described it excellently because the real world settings, when you don't have too much control, it's just you just have to wait and see how things play out. Really,
I think that's the thing, is that you don't have the control. That's why you get the chaos.
Yeah. So maybe it's patience as well, because sometimes you just kind of have to let things play out a little bit, and then you can see what you need to do, how it's coming together. So so maybe it's a combination of chaos and patience.
Yeah.
I like that.
If you could have a billboard anywhere in the world to share one key takeaway from your research, what would it say?
There's only so much you can do to prepare.
Oh.
I like that.
Yeah.
The chaos theme.
It's on theme.
I think I would say, just go for it.
Yeah, that's a great one.
That's a good one as well.
Yeah.
I prefer this hat,
Is it? Yeah.
Yeah, it's just nicer to put your hand.
Actually, it's very soft.
What's one thing you wish you had more time to spend on?
have to be a research thing, or can it
No,
be anything?
yourself.
No, it can just
It can be yourself. Anything.
Well, everybody who I work with knows me as the textiles queen. So I absolutely love textiles. So you can imagine what field trips to South Asia are like for me.
Oh, wow.
So I would say that I would like to have a little bit of time at the end of my field trips to go fabric shopping.
Oh, yeah.
Okay. Perhaps it could be arranged.
I think so. I think you could definitely arrange that.
Oh, yeah. I think, sorry. I was just thinking about Karen and shopping.
I do always come back with a suitcase full of fabrics.
I bet you take an empty suitcase with you.
As well as I take minimal and come back packed.
I think for me, I would like to, again, it's not research based. It's more like I would like to engage in some sort of, to learn how to paint, basically.
Oh, great.
What do you mean? Picture paint?
Yes,
Oh,
yes.
right.
I think I really enjoy looking at paintings and other people's work. So this is something that I would like to do as well.
Yeah. Oh, that's lovely. Yeah. Oh, you should definitely. I'm sure you'll be able to
You can fit that
find
in.
some kind of art class around.
Yeah.
Oh, yeah, that's great. Which emoji best represents your research?
Oh, that's easy. That's the one with the person with their hands up and just peeping through.
The one that's like scared to look.
Because you've gone and done something and it's like, whoa, how's that going to go?
Yeah.
Which is
that's
really
great.
exciting. But sometimes you're a little bit like, oh.
Yeah.
I like that one.
Yeah. I think for me, it would be that emoji where they're smiling and they've got tears coming out of their eyes.
Oh, yeah.
It's because, sometimes you don't know whether you want to be happy or sad, how things are going. And then, just trying to understand what's happening, really.
Yeah. You don't know whether to laugh or cry.
Exactly. Whether it's a good thing or a bad thing.
Oh, God.
Don't
cry now.
Yeah.
Keep laughing.
Which we also sort of, when we had, some issues with, the challenges with the implementation work. And we were like, even this would be a finding if, for example, the collaborative care model cannot be implemented, really.
Yeah.
So it's just, looking at the bright side. So, it's not always all doom and gloom,
Definitely.
Yeah.
Yeah, I think even when it's chaos, you're learning from
Absolutely.
the chaos.
Yeah.
Let's do one more.
One more. What's your favourite way to unwind after a long day of research?
Sewing machine out.
Oh, yeah.
Yeah. So I like to do some sewing.
Yeah, get some nice fabric.
You use your brain in a different way, and you have to focus on that. So you can't be thinking about anything else.
It's a good way to relax.
Yeah, and nice to do something like creative, maybe, as opposed to your kind of more academic work.
Mm-hmm.
I'd like to say I like to cook.
Oh, good.
Yeah. So it just helps me unwind. I find it very therapeutic.
Yeah.
And then you can eat at the end of it as well.
Yeah.
Oh, perfect. Yeah. Oh, that's a good one. Wow. Yeah. I feel like we've got very talented guests. We've got.
Oh, yeah. Sewing and cooking. And
and a soon-to-be artist.
But disclaimer, it doesn't mean that I cook very well. It's just that I like cooking.
I'm sure you do.
You don't have to tell us that. You should cook.
Oh, well, thank you so much for coming into the research room today. It's been so nice to chat to you and a really interesting project. We'll be looking out for the results. When do we think the results will be out?
So currently we've got our protocol paper just brand new, shiny, accepted for publication.
Oh, great. So there'll be a paper to read soon?
Yeah.
Oh, great.
The results we anticipate would be out by next year.
Okay.
Yeah, once we start capturing the data and then analysing it.
Yeah, looking through all your masses of different data that you'll have.
Then you come back and tell us what happened.
You'll have to come back and tell us all about the results.
Absolutely.
Lovely. Well, thank you so much for having us.
Of course, thank you so
welcome.
much. Yeah. So we'll put information about the study in the show notes so everyone can go there and find some links to websites and things. But yeah, just to say thank you and goodbye.
Bye. Bye.
Thanks. Bye.
Thanks. Bye. Don't forget to like and follow The Research Room wherever you get your podcasts. And if you'd like to leave us a review, that really helps other people find the podcast.
Does it?